Hello.
Hello, ma'am.
കേൾക്കാമോ?
കേൾക്കാം മാം.
കേൾക്കാം. ശരി ശരി. ഓക്കെ ഓക്കെ ഫൈൻ. സ്റ്റാർട്ട് ചെയ്യട്ടെ?
സ്റ്റാർട്ട് ചെയ്യാം മാം.
ഹലോ, സ്റ്റാർട്ട്
start
ചെയ്യട്ടെ?
ചെയ്യാം, ma'am.
എനിക്ക്
കേറിക്കൊണ്ടിരിക്കുക.
ശരി. എനിക്ക് സ്ക്രീൻ ഷെയർ ചെയ്യാമല്ലോ അല്ലേ?
പറ്റും മാം.
ഓക്കെ ഫൈൻ. സ്റ്റാർട്ട് ചെയ്യാനാവുമ്പോ പറയണേ.
മാം സ്റ്റാർട്ട് ചെയ്താ മാം.
സ്റ്റാർട്ട് ചെയ്തോട്ടെ?
സ്റ്റാർട്ട് ചെയ്യാം.
Sure. Okay, so today's class will be about optic nerve, the anatomy and diseases of optic nerve. So briefly about the optic nerve anatomy. See, I think carefully, because even though it is an afternoon session, you may be feeling asleep, but you listen carefully. This is very important, not just for ophthalmology, but for your future medicine, everything, all those aspects also. It is very important to learn about the optic nerve, and I'm very detailed about all these things, but just brief about the anatomy and the diseases, a few important diseases. Okay, that's all. Rest of the part you will have to read from the text. Okay, so this is basically from the examination point of view to diseases. I'll just make you familiar with, and we'll have a short discussion. Okay, so optic nerve anatomy. Okay, yeah. So as you all know, optic nerve, it is a second cranial nerve. Okay, so it is a second. When you enlist the 10 cranial nerves, it is a second cranial nerve. And with regard to the eye, it is starting from the optic disc. Okay, so it starts from the optic disc and it extends up to the optic chiasma. That is the extent of the optic nerve. So it is so for how it is formed, it is a continuation of the nerve fiber layer of the retina, which are actually the axons of the ganglion cell. So you have to be familiar with the anatomy of the retina there. So see, when you learn about the visual pathway, photoreceptors, it is the rods and the cones. So they are the photoreceptors. So they are the receptors of the visual pathway. They send, so they capture the visual stimuli and they send the signals to the bipolar cells, which are the first neurons in the pathway. Then from the bipolar cells, it goes to the ganglion cells, which are the second neurons. So the second order neurons, they continue as the axons, and these axons of these ganglion cells all they collect together to form the optic nerve. So where does they form? They join at the optic disc to form a single bundle of nerves, which is called the optic nerve. And in addition to the visual pathway, it also contains fibers of the light reflex pathway and also some centrifugal back. Okay, so as you all know, it is actually the optic nerve. It's a cranial nerve. It is an extent of the brain. We call it is an outgrowth of the brain. Why do you call it so? Because it is covered by the meninges, the pia, the arachnoid, and the dura. So you can call it an outgrowth of the brain, and it is similar to the of the brain. There is a sensory tract, and it is not covered by neurilemma, so it will not regenerate. So that is important, because in conditions any trauma or any inflammation affecting the optic nerve, it is a permanent injury to the nerve and its function. Okay, so for learning better, you classify the parts or divide the optic nerve into few parts where the actual length is about 5 centimeters. You divide them into 4 parts. So the intraocular, that is the smallest one, which the optic disc, which is only 1 millimeters. That is a part of the optic nerve that you can see ophthalmoscopically. With an ophthalmoscope, you can literally you can see the, or you can see the starting or the beginning of the optic nerve. Then you have the intraorbital part, which is 3 centimeters, reaching up to the optic canal, that is forming the intracanalucular part, which is about 6 to 9 millimeters. And then you have the intracranial part, which is about 1 centimeter. This is important. You should know the 4 parts of the optic nerve. The intraocular, which is the optic disc or the optic nerve head, as you call. Then the intraorbital part, canalicular part, which travels in the optic canal, which is a bony canal. And then you have the intracranial part. Okay. Now, the intraocular part, it passes through the sclera, choroid, and it appears in the eye as the optic disc, which is about 1.5 millimeter diameter structure. And it expands to 3 behind the sclera because of the presence of the myelin sheath. And it is divided into the sensory nerve fiber layer, the prelaminar, the lamina cribrosa, and the retrolaminar. This is lamina cribrosa. It is a sieve-like opening in the sclera through which the nerve fibers penetrate and they finally form the optic nerve. I'll show you the picture. So this is the nerve fiber layer. Okay, so that is a nerve fiber layer. They are coming and joining, they are collecting together to form the optic nerve. So this is the pre-arsa, and this is the lamina cribrosa. That is the sieve-like, scleral opening. This is known as the lamina cribrosa. That is a lamina. You have the retrolaminar part. So that is beyond the sclera. Okay, and this is another picture that shows the optic nerve head. See, from both sides you have the fibers coming, forming the optic nerve head at the or of the optic disc, and then you have the prelaminar part, the laminar part, and the retrolaminar. See why you want to divide the small region into these 3 parts. The importance is regarding the blood supply of this part. So each part has got a different blood supply. So the diseases in each vessel can produce different problems. Okay, that is why you divide it into three parts. Now, the intraorbital part, that is the one that is extending from back of the eyeball to the optic foramina. So you have an optic, that is optic foramina is opening into the optic canal. So globe and optic foramina is the intraorbital part. So it is actually, it's not a rigid structure. It is actually a curve, like a sinusoidal curve on. It is not very rigid because the eye is always moving. The eye has to move, so it has got, you have to give some place for the eye to move. And this part is covered by the dura, the arachnoid, and the pia. As I already told you, it is covered by the meninges. That is why you call it. It is an outgrowth of the brain. Now, this pile sheath contains what? Capillaries, and these capillaries, they supply the nerve. Okay, so pile plexus. So this is in fact the structure of the anterior optic nerve. In this, you can again see the anterior most part, the optic disc, and the intraorbital part, which are supplied by these are the pile plexus or the pile vasculature that is supplying the optic nerve from outside. You also have the branch of the ophthalmic artery, that is a central retinal artery going in, but it does not give much contribution to the blood supply of the optic nerve. It plays actually it going into the retina. It just passes through the optic nerve. Okay, so the blood supply is by the pile plexus in this part. And you can see, look at this vessel. This is the short posterior ciliary artery, which is a branch of ophthalmic artery. So the branches from the ophthalmic artery is responsible for supplying the optic. The anterior most part is supplied by the short posterior ciliary arteries, and the intraorbital part is mainly supplied by the pile plexus, which is arising from the network along the pile covering. Now, so this is another picture. Just I want to show you how the optic nerve is lying. So from the intraorbital part, you can see many blood vessels in relation. The one are the ophthalmic artery. So you can see the major and other nerves also. See the ethmoidal vessels and nerves, all these are going along with the optic nerve. Now, coming to the intracanalucular part. The intracanalucular part is in close relationship with the ophthalmic artery. So, when you study the structures passing through the superior orbital fissure, you draw a circle, that is optic foramina. And this optic foramina laga rendu structures, that is the optic nerve and the ophthalmic artery. Okay, so this intracanalucular part is important because it is closely related to the sinuses. Which sinuses? The sphenoid and the posterior ethmoidal sinuses. So any infection affecting those sinuses can lead to inflammation of the optic nerve. So that can result to what the term, that is the retrobulbar neuritis. Okay. So any infection of the sinuses can lead to retrobulbar neuritis. Retrobulbar means that is a part behind the eye bone. That is why you call it retrobulbar neuritis. Now, next is the intracranial part. So intracranial, it is extending through the cavernous sinus. That is, it is passing above the cavernous sinus, and then it goes and it converges to meet its fellow from the other side over the diaphragma sella to form the optic chiasma, and there it ends. And this part is also ensheathed in pia mater, and it receives the arachnoid and the dural sheaths at the point of its entry into the optic canal. So see, this is another picture. As I already told you, just a summary of this. See, this is the optic foramina. See, the intraorbital part entering into the optic foramen. The entire optic nerve you can see here. Okay. This is a short posterior ciliary artery supplying the optic disc and the pial plexus. And you can also see the central retinal artery. Okay, so coming in, so that's in just a summary about the anatomy of the optic nerve, and you should know some important things. So this is an important aspect. That's why I just I thought I'll just discuss it here. See the visual pathway and its lesions. See, a lesion which is affecting the optic nerve on one side, it will produce a complete blindness on that side. And there will be absent light reflex. That is, the patient will have a relative afferent pupillary defect in that side, and the opposite consensual reflex will also be lost. That means the afferent pathway is lost. Okay, so they will have an RAPD on that side, and the direct reflex is lost on that side, and the consensual is lost on the other side. And the accommodation reflex will be present. That is, the near response will be present. So it can be due to anything. That is, it can be an optic atrophy or a traumatic avulsion of the optic nerve or an acute optic neuritis. So any lesion which is affecting the optic nerve will produce a complete blindness on that side. Now, any lesion through the proximal part of the optic nerve, it can produce an ipsilateral blindness. See, I'll go to the picture. See, this is what I want to see. See, look at this side, this picture. You can see you can see this picture. 1 second. Okay, so this picture, you can see the optic nerve is cut right here, and there is a total blindness of the ipsilateral eye. That is a picture. That is a field defect A. Now come to the second point. This is a lesion affecting the optic chiasma. See what is happening in the optic chiasma. See, I told you there's optic nerve coming from the right eye, go meet the optic from the left eye, and they combine, they form the optic chiasma. So at the optic chiasma, what happens? There is crossing of fibers to either side. So the nasal fibers or the medial fibers from one side will cross to the opposite side on from both the optic nerve, whereas the temporal fibers, they pass uncrossed to the same side. So what happens here? So when there is an lesion involving the midline of the midline, it will affect the, I'm sorry, I'm getting some call in between. Okay, so it is affecting the fibers, the nasal fibers on both sides. See, the nasal fibers on both sides contribute to the temporal field of vision on in both the eyes. See, can you make, is it clear from this picture? This is a field of vision. Suppose this is a field of vision. This is a temporal. The light, the gray colored is a temporal part, and the black one is a nasal part. So the temporal field is by the nasal retina, and the nasal field is by the temporal retina. So when the nasal fibers are gone, what happens? Both eyes, the temporal field of vision will be lost, and hence you get a bitemporal heteronymous hemianopia. Even if you forget that term heteronymous, I don't mind. You should know bitemporal hemianopia. That happens when there is a lesion of the optic chiasma, especially when it is affecting the midline of the optic chiasma. And what is the commonest lesion? Do you know? It is a pituitary macroadenoma that is compressing the optic chiasma. The most common lesion is a pituitary macroadenoma compressing the optic chiasma. The patient will come to you with, may not come to you with any defective vision. Only on evaluation you can find out that the patient has lost his temporal fields on both sides. Now, so that is for the midline lesion of the optic chiasma. Now, if it's a lesion of the affecting the temporal or the lateral side, it's the temporal fibers or the temporal fibers of the optic chiasma. Temporal fibers of the optic chiasma, it will produce an ipsilateral nasal hemianopsia. Is that clear from this picture? See what happens. It is a temporal fibers of that eye is formed. So you have a nasal, a loss of field on the nasal field of vision. So the nasal field of vision is lost on the same side. That is an ipsilateral nasal hemianopsia. And since it occurs only on one side, usually you will not get any problem in the other eye. But രണ്ട് സൈഡും കൂടെ സൈഡിൽ നിന്ന് പോകുന്ന ചാൻസസ് കുറവല്ലേ. പക്ഷെ മിഡ്ലൈൻ ലീഷൻ ആകുമ്പോഴത്തേക്കും രണ്ട് ഐനെ ബാധിക്കും. So an ipsilateral nasal hemianopia you get in a lesion which is compressing the optic chiasma from one side. Okay. Now, any lesion that is producing a damage to the optic nerve beyond the optic chiasma is going to produce a homonymous hemianopia on the opposite side. Okay, so you get a contralateral hemianopia. So depending upon the site, the amount of field defect will vary. So till here you are getting an ipsilateral lesion. Okay, I told. So optic nerve, you get a field defect of the ipsilateral eye. The optic chiasma also you get an ipsilateral hemianopia. But beyond the optic chiasma, all the field defects are on the contralateral side. See what happens when there is a lesion here. The optic tract is affected. The optic tract or the optic radiations are affected. You get a contralateral homonymous hemianopia. See, there is a field defect on the other side in both the eyes. So you have a temporal defect in this eye and a nasal defect in this eye. Now, based on the, I told you based on the site of the lesion. Suppose it is a, look at this, if it is a parietal lobe lesion, parietal lobe. So look at, you have to imagine parietal lobe is lying in the upper part of the brain. Okay, so a parietal lobe lesion, it will produce a quadrantic anopia. So only few fibers are lost. So you get a quadrant anopia, which is in the lower part. So that is called the pie on the floor visual field defect. Okay, this word is important, pie on the floor visual field defect. And similarly, a temporal lobe lesion, that is a temporal lobe is lying on the lower part, and you have to imagine that the temporal lobe lesion will produce a pie in the sky optic quadrant anopia. Okay, on the, everything is on the contralateral aspect. So a contralateral hemianopia, but only a quadrant anopia. So parietal lobe will produce a pie on the floor lesion and temporal lobe will produce a pie on the sky. ഇത് ഒരിക്കലും മറക്കാൻ പാടില്ല. ഇത് നിങ്ങൾ എത്രയായാലും ഓർക്കുന്ന ഒരു കണ്ടീഷൻ ആയിരിക്കണം. See, for medical neurology, everything this is important. So a parietal lobe lesion will produce a contralateral pie on the floor, and the temporal lobe lesion will produce a contralateral pie in the sky visual field defect. Now coming to the visual field radiation from the occipital area, see occipital area, the visual field, it represents a wide area. So any lesion in that usually, and one more important thing is that the macular region has got a very large area of representation. So the lesions usually result in homonymous hemianopias with macular sparing, because the macular area korchu valiya area ആണ് represent ചെയ്യുന്നത്. So usually the macula is not affected. The macular sparing will be seen in occipital lobe lesions. So this is in brief about the visual field defects in the different lesions affecting the visual pathway. This picture is important. You have to learn it. You draw it and you learn it. Okay. Now, coming to the optic nerve head, or which we are concerned here today. So how do you evaluate, or how would you see the optic nerve? This instrument you have to see, you might have seen this is our slit lamp. Okay, this is our slit lamp biomicroscope. It has got a microscope like lenses here. And by using these lenses, these are the 90 diopter lenses, you can you can actually see the optic disc. This is how the optic disc appear as you see through the 90D lens through the slit lamp. So you can see the optic disc, and also you can see the blood vessels coming out and going into the optic disc. You can see the very pink colored optic disc in this picture. Now, what is this optic optic nerve head or the optic disc? So just for learning it better, you learn that it has got three parts. There's a central depression, that is a cup. A cup is a part which does not contain any optic, nerve fiber layers. Now the disc margin, that is the disc margin, which is formed by the scleral ring. So till here you have ring. Okay, so beyond that there is only the sieve, that is a lamina cribrosa, net polate aripa polate bhagam. Now, so this is a scleral ring that forms margin, and this part, that is the most important part, that is called the rim or the neuroretinal rim, which contain all the retinal nerve fiber layers, and the central part is called the cup of the optic nerve head. Okay, so this is the picture of the optic disc. That is the optic disc margin. This is the rim which contains the nerve fiber layers or the axons of the ganglion cell layers, and this is the optic cup, the central depression, that is called the optic cup. ഇതിനെയാണ് നമ്മൾ cup disc ratio എന്നൊക്കെ പറയുന്നത്. Vertical cup, the cup to disc. This is a vertical disc diameter, the vertical diameter of the disc, and this is the vertical cup diameter. This is important in the cases of which cases? This is important in glaucoma. So when there is an enlargement of the cup, as there is progressive loss of the neurons, what will happen? The cup size large. So that is why you say there is an increase in the cup disc ratio. എന്നൊക്കെ പറയുന്നത് ഈ പ്രൈമറി ഓപ്പൺ ആംഗിൾ ഗ്ലോക്കോമയുടെ നമ്മുടെ ഫോളോ അപ്പിനും അസസ്മെന്റിനും ഒക്കെ വേണ്ടിയിട്ടാണ് നമ്മൾ ഈ കപ്പിന്റെ ഡയമീറ്റർ സൈസ് ഒക്കെ അസസ് ചെയ്യുന്നത്. And you can also see the disc vessels, that is the veins, and you can also have the arteries. So usually the vessels, the blood vessels, the veins are darker in color and the arteries are light in color. So which is the artery? It is a central retinal artery and its branches, and the vein, it is a central retinal vein and its tributaries. Now coming to the diseases of the optic nerve, I am discussing only two diseases. One is optic neuritis and the other is papilledema. So we'll go with just a case scenario. ഓരോരുത്തരും വിളിച്ച് ചോദിക്കാൻ പറ്റത്തില്ല, എന്നാലും നിങ്ങൾ ശ്രദ്ധിച്ചിരിക്കുക. വാട്ട് ഇസ് ഇറ്റ്? യു ഐഡന്റിഫൈ വാട്ട് ഇസ് എ ഡയഗ്നോസിസ്. See, a 37-year-old man with cerebral venous sinus thrombosis. He is having some inflammation of the blood vessels inside the brain, and there is a thrombosis of the venous sinus. You should know what is the venous sinus. They are the major drainage of the blood from the brain. Okay. So that is that veins are thrombosed, and the patient is coming to you with severe headache, projectile vomiting, and mild blurring of vision. So headache and projectile vomiting, it is a sign of what? It is a sign of a raised intracranial tension. And he is also complaining of mild blurring of vision or mild diplopia. All this he is complaining. And the medicine people, they have already done an MR angiography, and you can see this is the picture of the venography showing an obstruction of the right transverse and the sigmoid sinus. There is no blood flow. So this is a venography. You can see the white blood vessels of the brain. See, this side, left side, normal blood flow ഉണ്ട്, പക്ഷേ right side blood flow കാണുന്നില്ല. So the right transverse and the sigmoid sinus is thrombosed, and the patient is having severe headache, vomiting, all this thing. And I'm sorry. Oh God, what happened? One second. Okay, So this is the you have done an ophthalmoscopic evaluation, and this is how the optic disc in both eyes are looking like. So what is the diagnosis? Anybody? Is anyone listening?
Hello.
What is the diagnosis? Hello. Can anybody say what is the diagnosis? I told you, a patient coming with a obstruction of the cerebral venous thrombosis or a block cerebral venous thrombosis is having headache, raised intracranial pressure, and this is how his optic disc is looking like. Leah, are you there?
Yes, ma'am.
Yeah, what is the diagnosis? What is this? What is this? What is your diagnosis? Did you understand?
Papilledema.
Papilledema, yeah, exactly. This is papilledema. Okay, so this is a simple, straightforward question. Okay, so what is that you see in this picture? What is the problem in the picture?
Optic disc.
I showed you a normal optic disc, isn't it? I showed you how a normal optic disc is looking like. It's having a well-defined disc margin, a cup is there, blood vessels, everything is there. What is the problem with this? Here you cannot make out anything like that. See, here it is a disc margins are blurred. It is edematous. So in fact, it is a disc edema. Both sides, the disc is severely edematous. I'm going to push in the so, and it is bilateral. And see close, if you look at the disc, see, look at the left disc, it is very clear. You can see the blurred disc margin. You can see the blood vessels are slightly congested. So you can see the venous engorgement. That is a vein that is slightly engorged. And you can see the edematous disc margin, and the you can see the peripapillary hemorrhages. All these are present. And can you make out the cup as I showed you in the other picture? You cannot see the cup. That is why the cup is obliterated. That is because of the severe edema of the optic nerve. So this is a diagnosis of papilledema. So so we'll just discuss and the sign causes and discuss it. So just another picture. See, this is how a normal optic disc will look like, and an optic disc in papilledema will look like. Okay, so what is papilledema? It is a swelling of the optic nerve as it enters the back of the eye due to raised intracranial pressure. So disc edema secondary to a raised intracranial pressure due to any cause is called the papilledema. And it is so papilledema it is assume it is always bilateral. So because it is continuous, the side it is bilateral. So papilledema is the swelling of the optic nerve due to any cause that produces a raised intracranial tension. And initially, see, because it is a passive edema, see, the edema is spreading from the brain through the CSF. It is pushing the optic nerve. It is not primarily affecting the optic nerve. So it is actually a passive edema. It's not an active swelling of the disc as such. So since it is a passive edema, the optic nerve function is not affected much. So in initial period, early papilledema, the patient will not have any defective vision, will not have any other complaints. Only his main complaint will be about the headache because of the raised density. But if there is persisting, see, as the papilledema remains there for some time, what happens? There will be mild problems with the function of the optic nerve. Then the patient will have blurring of vision. There can be double vision, some flickering. They will say some transient obscurations of vision, or eventually, if it remains long, if it becomes a chronic established papilledema, the patient can lose vision. Okay. So that is papilledema. And so typically in early signs, there will be no RAPD. Why? Because there is no optic nerve dysfunction. So that is an important sign. So you are looking at the optic disc, it appears very horrible, but you are looking at the patient, he has good vision and there is no RAPD. That is how you differentiate papilledema from other conditions. Okay. So these other signs, which I already explained to you, the venous engorgement, loss of spontaneous venous pulsation. See, there is something called a spontaneous venous pulsation. See, these SVPs are actually some transmitted pulsations from the brain. Okay, you can see when you look at the disc, you can see some transmitted pulsations of the weight that is transmitted from the brain. So when the pressure inside the CSF increases, what happens? This will be stopped. So when there will be loss of the spontaneous venous pulsations when there is the raised intracranial pressure. And when the congestion, discal congestion kodumba, there will be hemorrhages. There will be hemorrhages adjacent to the optic disc, blurring of the optic disc margin, elevation of the optic disc. The disc actually it is lying normal, or it is in level with the retina. It will elevate. It will elevate above the retina. And there are some patterns lines. What are these patterns lines? They are the radial retinal lines cascading from the optic disc. See, if you look closely, you can see. But circular lines നമുക്ക് ഇവിടെ റെറ്റിനലോട്ട് പോകുന്നത്. ഇറ്റ് ഇസ് ബിക്കോസ് ഓഫ് ദി എഡിമ. ആ എഡിമ വന്നിങ്ങനെ തള്ളുന്നത് കാരണം വരുന്ന റെറ്റിനൽ എഡിമ, പെരിപാപ്പുലറി റെറ്റിനൽ എഡിമയുടെ ലൈൻസ് ആണ്. ദേ ആർ ദ കോൺസെൻട്രിക് ലൈൻസ് seen in the peripapillary retina, which is classically or typically seen in disc edema due to papilledema. Now, I told you there will be no problem with the vision, but there will be some problem with the visual field. What is it? It is only it is not a problem. It's actually a mild enlargement of the blind spot. So before telling about that, I just want to you to know that what is this blind spot? See, in the visual field, there is a portion which is corresponding to your optic disc. Our optic disc in the portion, there are no photoreceptors. That is why you get a blind spot. It is a dark spot in our visual field. Visual field blind spot. Have you tried? Have you tried identifying your blind spot? It is very easy. In class, you find out how it is, and you have namakku blind spot identify cheyan pattum. Oru pencil matram madi. ഒരു പെൻസിൽ വേണം, ഒരു വൈറ്റ് വാൾ വേണം, അതിലൊരു ഡോട്ട് ഇട്ട് നമ്മൾ അതിലോട്ട് നോക്കിയിരിക്കുക, ആ ഡോട്ടിൽ തന്നെ നോക്കിയിരിക്കുക. ആൻഡ് യു മൂവ് ദ പെൻസിൽ സ്ലൈറ്റ്ലി, ഇങ്ങനെ നമ്മൾ ടെമ്പറിലോട്ട് മൂവ് ഒരു പോയിന്റ് വരുമ്പോഴത്തേക്ക് ആ പെൻസിൽ ടിപ്പ് നമുക്ക് കാണാൻ പറ്റില്ല. You should be looking at the point, and that point corresponds to your blind spot. So you have two blind spot on your either side. That is on the temporal field. രണ്ട് blind spot on. So what happens when the disc edema happens? There will be stretching of this the scleral ring, adake stretching. So what happens? There will be an enlargement of the blind spot. That is a field defect in, or that is in a field defect in our parila. This is a blind spot which is slightly enlarged. That's it. The patient will not appreciate anything. That is an enlarged blind spot. Now, causes I already told you. These causes you should know. Brain tumors or intracranial space occupying lesions, ICSOL. Okay, then certain medicines like tetracyclines, certain old medicines, then hypervitaminosis A, Foster-Kennedy syndrome. What is this Foster-Kennedy syndrome? Tumors of the frontal lobe. So frontal lobe tumors, they occupy, what happens is that as they grow, they will produce raised intracranial pressure. പക്ഷെ കുറച്ചുകൂടെ ഗ്രോ ചെയ്യുമ്പോൾ എന്ത് പറ്റും? They will go and directly compress the optic nerve. So they will produce a compressive optic neuropathy and optic atrophy on that side. പക്ഷെ മറ്റേ സൈഡിൽ ഡിസ്ക് എഡിമ ഉണ്ടായിരിക്കും. സോ പാപ്പിലെഡിമ തന്നെയാണ്, പക്ഷെ ഒപ്റ്റിക് കുറെ നാൾ ലോങ് സ്റ്റാൻഡിങ് ആയിട്ടിരിക്കുമ്പോൾ ആ അഫക്റ്റഡ് സൈഡിൽ optic atrophy ആയിപ്പോ. But when you look at the fundus, what happens? You can see optic atrophy on that side and disc edema on the other side. So അപ്പൊ നമ്മൾ മറ്റേ സൈഡിൽ എന്ത് പറ്റിയെന്ന് വിചാരിക്കും. So that syndrome is called Foster-Kennedy syndrome, which is characteristic of tumors of the frontal lobe. Then certain conditions like Arnold-Chiari malformations, malignant hypertension, all these are causes for papilledema. Now, that is about papilledema over. Now, coming to, this is a second thing. This is another case scenario. A 22-year-old male MBBS student, he has come to you with a blurring of vision in right eye. Okay, so he's telling he's having mild blurring in right eye. He's having headache since 3 days. And the typical complaint is he's having pain on eye movements. But sinusitis polte vedanayana, kanna anakkumba vedanayundu, adana his complaint. So there will be pain on eye movements, especially elevation and adduction. See, when I showed you that picture, I didn't mention about that. See, intraorbital part of the optic nerve is extending up to the optic foramina. Optic foramina, there is something called a circle of sin, or tendinous circle of sin. What is this tendinous circle? This is actually the origin of the recti muscles in the origin, extraocular muscles in the origin. So, and this tendinous ring, it is in close relation to the optic nerve as it enters the optic foramen. And few fibers of the superior rectus and medial rectus are in contact with the optic nerve sheath in that area. That is why when in case of optic neuritis, I'll come to you, in case of optic neuritis, there is mild pain. The patient will have pain on eye movements, especially when he is elevating superior rectus and adduction, medial movement, elevation, and the patient will complain of pain. And examination, his vision will be 6-12, not very bad, but 6-12, but there will be a definite relative afferent pupillary defect in right eye. See, as against the other thing, I told you, see, optic papilledema, passive edema, this is active edema. This is active edema, and there is an active edema. So what happens? There is function. The optic nerve function will be affected. So there will be a relative afferent pupillary defect. The optic disc and fundus appear normal. What does it mean? See, upon examination, the optic disc and fundus appears normal, but the diagnosis is right optic neuritis. Can anybody tell what is the problem here? Am I written something wrong, or can it happen? Leah, Suhail, Suhail.
Hello, ma'am.
Can this happen? See this picture. I have given a case scenario. A student, we are diagnosing it as an right optic neuritis, but examination, he has a decrease in vision and there is an RPD in right eye. There is an optic nerve dysfunction on examination, the optic disc and fundus are normal. Disc edema or hemorrhages. Can this happen? Can it happen? Is it possible? Why? How can it happen? Diagnosis. So optic, so complete diagnosis right optic neuritis. It is a retrobulbar neuritis. Yeah, it is a yeah, exactly. So that is correct. So it is a retrobulbar neuritis. So in optic neuritis, fundus problem. Okay. So, fundus affect fundus findings disc edema, hemorrhages, then you call it papillitis, that is inflammation affecting the optic nerve head. Optic nerve head in inflammation papilledema, papillitis disc hyperemia, disc edema. Okay, so this is right optic neuritis. So what is optic neuritis? It is inflammation of the optic nerve due to any cause. The most common cause is a demyelinating event associated with multiple sclerosis. Okay, so the most common cause of optic neuritis is most common causes but it is one important cause. It is a demyelinating event such as associated with multiple sclerosis. So typical optic neuritis, these are the important features. So it is acute or subacute monocular vision loss. The age group is 20 to 50 years, 20 to 40. You can say 20 to 40 years, more in females. Pain, which is induced or worsened by eye movement. And there is peak vision loss within 2 weeks of onset. And after 2 weeks, it starts improving. And there will be a relative afferent pupillary defect. That is the optic nerve dysfunction is there. Mild color vision and contrast sensitivity. This is also very important. See, color vision and contrast sensitivity. These are not affected in papilledema, but in optic neuritis, there will be poor color vision. The color vision will be defective, and the contrast sensitivity will be reduced. Then, what about the visual field defect? The patient will have a typical central and paracentral scotoma. So this is a central. See, this is our visual field. This is a central point. So you have a typical central and paracentral scotoma. And what is this VEP? VP is the visually evoked potential, which is an optic nerve test, evaluation test. So there will be a prolonged latency of the visually evoked potential. So VP will show a prolonged latency. These are features of an optic nerve, typical features of optic nerve. Now, how do you classify optic nerve? This is a question. So it can be retrobulbar neuritis or papillitis or neuroretinitis. So you should know about both these. You should know these three terms. You should know. It can be retrobulbar neuritis or papillitis or neuroretinitis. And depending upon the etiology, you can classify it into demyelinating, that is following multiple sclerosis. And commonly, there are some infections, like especially the viral infections. Measles, mumps, rubella, chickenpox, all these infections, infective viral etiologies can produce a post-viral optic neuritis, post-viral optic neuritis. Then autoimmune etiology, and a few cases can be idiopathic as well. Okay, so okay, so yeah, so there's something happened to my slide. Okay, see this, I just wanted to show the three types, that is the retrobulbar neuritis, the papillitis, and the neuroretinitis. So look at this picture, papillitis. I don't know why it came small. See, papillitis, you see, it looks like it is a papilledema. It's like a unilateral papilledema. There will be edema of the optic nerve head, or the margins will be, margins will be blurred. There will be hyperemia. There will be hyperemia, and there will be some hemorrhages surrounding the optic nerve. So that is papillitis. Now this is retrobulbar neuritis. So you cannot make any findings on the optic nerve head. It appears normal. Typical all the classic teachers patient also cannot see anything, and you also cannot see anything. That you are the doctor. Okay, so the doctor also does not find any problem in the eye, but the patient also cannot see. So you are in trouble. So then the diagnosis is what? It could be a retrobulbar neuritis. And what is neuroretinitis? Neuroretinitis means along with the optic nerve, there is also inflammation of the surrounding retina. So then you get so many findings, like this edema. There will be something called exudates in the macular area, which is called a macular star. These are seen in certain viral certain infective etiologies like Lyme's disease, like borreliosis. All those things can produce us, or leptospirosis. All this can produce some entities called neuroretinitis. So this classification you should know. It is papillitis, retrobulbar neuritis, and neuroretinitis. Now, optic neuritis etiology, it is an acute immune attack. So that is why I call it a demyelinating event. So acute immune attack on the myelin, and so the conduction of visual information will be slowed. And there are HLA associations, especially in multiple sclerosis. So most cases presents as typical optic neuritis, and most of cases of multiple sclerosis can present as optic neuritis. Multiple sclerosis in demyelinating multi-system disease. In that optic neuritis can be a presenting symptom of multiple sclerosis. Appo 20-40 years young male multiple optic neuritis present, you have to follow him lifelong for development of multiple sclerosis. Okay, and the important investigation of choice is an MRI, a brain MRI, a gadolinium enhanced MRI. So what is this picture? This is typical. You should know this. Wherever you go, you should know this. What is like finding here? You can see white matter lesions in this in the brain MRI, which shows it tells you that there is a high risk of developing multiple sclerosis later. So the bright enhanced or inflamed optic nerve, that is what you see here, the brightly enhanced optic nerve on the affected side, and you can also see some bright spots in the white matter. Okay, and a picture, I don't know what happened to the picture. Okay, so periventricular area, in the periventricular area, this is a ventricle and this is periventricular area also. You can see the periventricular white matter lesions. All these are suggestive of multiple sclerosis. So when you have a patient with optic neuritis, if there is on first diagnosis or like first episode angle, you can just treat the patient. But if he is having no, you treat the patient and always have a baseline MRI. And if then in the baseline MRI there are no findings, you can just follow up the patient on regularly. But the baseline MRI, if it shows signs of demyelination, as I told you, you have to refer the patient to a neurologist, and you have to wait for or look for recurrent attacks, if there is any appearance of demyelinating lesions, any neurological symptoms, and you may have to go for further management of the multiple sclerosis, as you may start interferon therapy. So that is why it is important to follow up the patient and evaluate a case of optic neuritis in the first episode itself to look for a later development of multiple sclerosis. Okay, so first episode of optic neuritis. Now, how do you treat? This is you have something called an optic neuritis treatment trial, or ONTT trial. So this trial says that you have to treat the patient with intravenous methylprednisolone. That is a very strong, potent steroid, and you have to give it as pulse IV methylprednisolone, pulse doses of IV methylprednisolone, followed by oral prednisolone. And this will speed up the visual recovery as well as decrease the initial 2-year incidence of multiple sclerosis. Okay, so how do you give? High dose intravenous methylprednisolone 1 gram IV for 3 days, followed by oral prednisolone 1 milligram per kilogram for 11 days and 3 days taper. This dosage നിങ്ങൾ ആജീവനാന്തം ഓർത്തിരിക്കേണ്ട ഒരു കാര്യമാണ്. So you should remember this. See, high dose intravenous methylprednisolone 1 gram for 3 days, followed by oral prednisolone 1 milligram per kilogram for 11 days and 3 days tapering. Okay, so that is a dosage of methylprednisolone as per optic neuritis treatment trial. Now, so that was about optic neuritis and papilledema, and I'm just ending with 2 more slides. See, this is what will be asked for you in your exam. Give differences between papilledema and papillitis. അപ്പോൾ ഇതെല്ലാം നമ്മളിപ്പോൾ ഡിസ്കസ് ചെയ്ത് കഴിഞ്ഞു. I'll just go through that. See, papilledema, visual acuity will be preserved. The visual function is usually not affected, especially in the early papilledema, whereas in papillitis there is early optic nerve dysfunction and the vision will be affected. The visual acuity will be reduced. Then what about the visual field? There will be enlargement of the blind spot. There will be enlargement of the blind spot and mild loss of peripheral vision. That you don't remember. You just remember that there will be an enlargement of blind spot. Whereas in papillitis, there will be a typical central or centrocecal scotoma. Okay, central or centrocecal. Central means it is affecting the fixation point. നമ്മൾ എവിടെയാണോ നോക്കുന്നത് ആ ഫിക്സേഷൻ പോയിന്റിനെ എഫക്ട് ചെയ്യും. സീക്കൽ എന്ന് പറയുന്നത് ബ്ലൈൻഡ് സ്പോട്ടിനെയാണ് ഉദ്ദേശിക്കുന്നത്. അപ്പൊ സെന്റർ തൊട്ട് ബ്ലൈൻഡ് സ്പോട്ട് വരെയുള്ള ഏരിയയിൽ സ്കോട്ടമ ഉണ്ടായിരിക്കും. That is a central scotoma and a centrocecal scotoma. Then what about color vision? Color vision will be normal in papilledema, whereas in papillitis it will be defective. Pupillary reflexes, the direct and consensual reflexes will not be affected in papilledema, whereas in papillitis there will be a definite relative afferent pupillary defect. See, eye movements, there is no pain on eye movements, there will be pain on eye movements, usually unilateral ocular pain on moving the eyes. Then laterality, papilledema is always bilateral. There will be bilateral disc edema, swelling, all findings will be bilateral, whereas in papillitis it is usually unilateral. And the papilledema fundus examination shows absent venous pulsations, so that's a sign of raised intracranial tension. Okay, and in papillitis the venous pulsations will be present. And let me ask you one thing, what is RAPD? Can anybody answer what is RAPD? നമ്മൾ ഇത്ര നേരം RAPD എന്ന് പറഞ്ഞോണ്ടിരുന്നു. What is RAPD? Relative afferent pupillary defect. So, അപ്പോൾ നമ്മൾ എപ്പോഴും pupillary reflex നമ്മൾ പഠിക്കുമ്പോൾ 2 എണ്ണം ഉണ്ട്, ഡയറക്റ്റും ഉണ്ട്, കൺസെൻഷ്യൽ റിഫ്ലെക്സും ഉണ്ട്, അല്ലെ? സോ ഡയറക്റ്റ് റിഫ്ലെക്സ് എന്ന് പറഞ്ഞാൽ നമ്മൾ ഇപ്പൊ റൈറ്റ് ഐയിൽ ലൈറ്റ് അടിച്ചാൽ റൈറ്റ് ഐയിൽ നമ്മൾ കൺസ്ട്രക്ഷൻ കിട്ടുന്നതിനെയാണ് നമ്മൾ ഡയറക്റ്റ് റിഫ്ലെക്സ് എന്ന് പറയുന്നത്. റൈറ്റ് ഐയിൽ അടിക്കുമ്പോൾ കൺസെൻഷ്യൽ അപ്പുറത്തെ സൈഡിൽ കിട്ടുന്നതിനെ നമ്മൾ അതിന്റെ കൺസെൻഷ്യൽ റിഫ്ലക്സ് എന്ന് പറയും. സപ്പോസ് എ പേഷ്യന്റ് ഇസ് ഹാവിംഗ് എ റൈറ്റ് ഓപ്റ്റിക് ന്യൂറൈറ്റിസ്, ആ പേഷ്യന്റിന് റൈറ്റിലെ ഡയറക്റ്റ് റിഫ്ലക്സും പോവും, അപ്പർ സൈഡിലെ കൺസെൻഷ്യൽ റിഫ്ലക്സും പോവും. ഓക്കെ, പക്ഷെ ഇഫ് യു ആർ ഷോയിങ് ലൈറ്റ് ഇൻ ദ ലെഫ്റ്റ് ഐ, വാട്ട് വിൽ ഹാവ്, അതിൽ ഡയറക്റ്റും ഉണ്ടാവും, ഇപ്പുറത്തെ കൺസെൻഷ്യലും ഉണ്ടാവും. സോ വാട്ട് ഇസ് എ പ്രോബ്ലം ഹിയർ? ഇസ് only the afferent pathway is affected. അതായത് നമ്മൾ കണ്ണിന്ന് ബ്രെയിനിലോട്ട് അങ്ങോട്ട് പോകുന്ന പാത്വേ മാത്രമേ എഫക്ട് ചെയ്യുന്നുള്ളൂ. ദാറ്റ് ഇസ് വൈ യു കോൾ ഇറ്റ് എ റിലേറ്റീവ് അഫറന്റ് പ്യൂപ്പിലറി ഡിഫക്റ്റ്. രണ്ട് പാത്വേസിനും പ്രോബ്ലം ഇല്ല, ഇഫറന്റ് നോർമൽ ആണ്. Okay, only the afferent pathway is affected. The efferent pupillary pathway is strong. That is why you get a consensual response of the other eye. മറ്റേ കണ്ണിലെ ലൈറ്റ് അടിച്ചാൽ നമുക്ക് ഈ കണ്ണിലെ പ്യൂപ്പിൾ കൺസ്ട്രക്ട് ചെയ്യും. ഓക്കെ, പക്ഷെ ഇതിൽ ലൈറ്റ് അടിച്ചാൽ മാത്രമേ നമുക്ക് ഇവിടുത്തെ കൺസ്ട്രക്ഷൻ കിട്ടാതുള്ളൂ. ദാറ്റ് ഇസ് വൈ യു കോൾ ഇറ്റ് റിലേറ്റീവ്. സോ ദി ഡിഫക്റ്റ് ഇസ് റിലേറ്റീവ്. ഇറ്റ്സ് നോട്ട് an absolute defect. It's a relative afferent pupillary defect. Okay, so that is papillitis. Then one more small, this is also with regard to your exam point. You may be asked what is pseudodisc. നമ്മളിപ്പോ കുറെ നേരമായിട്ട് ഡിസ്കഡീമ എന്നുള്ള പറഞ്ഞിട്ടുണ്ട്. There are certain entities that can present which are normal. That means there is no optic nerve dysfunction, but they appear as edema of the optic nerve. പക്ഷെ ഇതില് എല്ലാം അങ്ങനെയല്ല. എക്സാമ്പിൾസ് ഒന്ന് ലൈക്ക് പ്രോബ്ലംസ് ഇല്ലാത്ത എക്സാമ്പിൾസ് ആണ് hypermetropic disc. See, hypermetropia എന്ന് പറയുന്നത് എന്താണ്? It is a refractive error. In hypermetropia, what is the problem with the eye? The eye globe is slightly smaller in size. ചെറുതാണ്, anteroposteriorly size ചെറുതാണ്. അതേപോലെ തന്നെ optic nerve head സൈസ് കുറച്ച് ചെറുതാണ്. So that small disc can appear as edematous disc. നമ്മൾ ophthalmoscopically നോക്കുമ്പോൾ margins ഒന്നും അത്ര ക്ലിയർ അല്ല, പക്ഷെ കുറച്ച് crowded disc ആണെന്ന് തോന്നും. So it can appear as a pseudopapilledema or pseudodiscedema. Then another thing is optic nerve drusen. Drusen എന്ന് പറയുന്നത് ഒരു ഡീജനറേറ്റീവ് ചേഞ്ച് ആണ് ഇത് റെറ്റിനൽ ഗാംഗ്ലിയോൺ. ആൻഡ് അത് കുറച്ച് ഡിപ്പോസിറ്റ്സ് ആയിട്ട് ഓപ്റ്റിക് നെർവ് ഹെഡിൽ ഡിപ്പോസിറ്റ് ചെയ്യും. സോ ഓപ്റ്റിക് നെർവ് ഹെഡ് ഡ്രൂസൻ ഇങ്ങനെ എന്താണ് ഹിഡൻ ആയിട്ട് അല്ലെങ്കിൽ ഇങ്ങനെ ആയിട്ട് ഓപ്റ്റിക് ഡിസ്കിൽ ഉണ്ടെന്ന് ഇറ്റ് അപ്പിയേഴ്സ് ലൈക്ക് എൻ എലിവേറ്റഡ് ഡിസ്ക്. സോ ഒഫ്താൽമോസ്കോപ്പിക്കലി നമ്മൾ നോക്കുമ്പോൾ ഇറ്റ് ലുക്സ് ലൈക്ക് എ ഡിസ്ക് എഡീമ. Okay, another condition is a hypoplastic disc. So the disc is not proper. You cannot make out the optic cup അല്ലെങ്കിൽ margin or clear. You can just see the the hypoplastic optic disc. That is also one variant for pseudodiscedema. And lastly, some infiltrations before they affect the optic disc function, like certain malignancies, secondaries, all these things, they can also mimic as a pseudopapilledema or pseudodiscedema. So we just learned these few names. That is, one is hypermetropia, an optic nerve head drusen, a hypoplastic disc, some infiltrations of the optic disc as in case of malignancies. All these are examples for pseudopapilledema. So these last two slides are നിങ്ങൾക്ക് എക്സാമിന് ഡെഫിനറ്റ് ആയിട്ട് ചോദിക്കാവുന്നത്. One is differences between papilledema and papillitis, and the other is give few examples of pseudopapilledema. Okay, അത്രേ ഉള്ളൂ. Thank you. So that's about today's class. Anybody have any doubt? Any doubt to be clear? Leah?
Yes, ma'am.
Okay, can you please send the attendance? Okay. എന്തെങ്കിലും ക്ലിയർ ചെയ്യാനുണ്ടോ? Anything else you want to know about, like വേറെ എന്തെങ്കിലും കൂടുതൽ എക്സ്പ്ലെയിൻ ചെയ്യണമെന്നോ അങ്ങനെ എന്തെങ്കിലും ഉണ്ടോ? ഒന്നും ഇല്ലായിരിക്കും.
ഇല്ല മാം.
ശരി. Okay, so I want you to go and read your past and with you optic neuritis എന്ന് പറഞ്ഞ ആ ചാപ്റ്റർ വായിക്കുക. Okay, at least by within 1 or 2 days you read that chapter. And actually it is a difficult portion. നമ്മൾ MBBS ലെവലിൽ വെച്ചിട്ട് ഒഫ്താൽമോളജിയിൽ ഓപ്റ്റിക് നെർവ് എന്ന് പറയുന്നത് ഒരു ഡിഫിക്കൽട്ട് പോർഷൻ ആണ്. അതുകൊണ്ടാണ് ഞാൻ എല്ലാം കൂടെ ഒന്നും പറയുന്നില്ല. ഇമ്പോർട്ടന്റ് ആയിട്ടുള്ള 2 എൻറ്റിറ്റീസിനെ മാത്രമേ ഡിസ്കസ് ചെയ്തിട്ടുള്ളൂ. നിങ്ങൾ അത്രയെങ്കിലും ഇൻ ഡീറ്റെയിൽ പാപ്പിലെഡീമയും ഓപ്റ്റിക് ന്യൂറൈറ്റിസും എന്തുവാണെന്നുള്ളത്, and how do you differentiate, and what is it actually എന്നുള്ളത് അത് രണ്ടും മാത്രം ഡിഫറൻഷിയേറ്റ്. Okay, thank you.
Thank you, ma'am.
ശരി, താങ്ക് യു.